Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into my latest video. It's of a patient who attended with bilateral fully occluding plugs of earwax. Now the patient was very anxious, quite sensitive, so it was a bit of a difficult case in that respect because as soon as I entered the ear and the patient heard the suction noise and I made contact with the surface of the wax, the patient was fidgeting quite a lot. And it's obviously quite difficult when we're doing these procedures because the ear canal itself, the diameter of an ear canal, so the average width of an ear canal, it does vary at different stages of the ear canal from the entrance to the eardrum. But on average, you're looking between 6 and 8 millimeters wide and around 7 to 9 millimeters in height. So it's a very small orifice that we're operating in, and any slight movement by the patient can obviously cause them to knock their ear against the instrumentation that we're using. So I had to really calm the patient down, I had to reassure them. On my ENT couch, I've got a headrest, so I asked the patient to sit back and relax. And I was just constantly talking to the patient throughout the procedure just to put them at ease, just telling them that what I was doing, and quite often, as you can see in the procedure, we weren't really entering the ear. All the instrumentation on the outer third, so there's no need for the patient to be worried at all. And so there's quite a significant blockage here. I had to use an ear hook just to break up the plug of wax, so it enables me to then suction it out of the ear. So this is the lateral posterior concha canal wall. There's a crusted piece of wax here. If I can elevate this off the canal wall as I am, it will then loosen the entire plug, which enables me to remove it out. So for those people who perform earwax removal, there's a bit of a weak spot. So if you've got a big plug of earwax, like in this case, when you enter the ear, so in the case of the right ear, which is the ear that we're working in at the moment, so there's a bit of a blind spot to the left, so to the posterior canal wall, which is the back part of the ear canal, near the entrance laterally. If you can loosen that, like I am here, it can then facilitate easier extraction of the rest of the plug. And you'll see the same technique in the patient's left ear. You'll see I was targeting the posterior lateral canal wall. Now, with an endoscope, you can visualise that because of the field of view. Some other visualisation techniques, for example, loops, which are like head goggles, and an otoscopic approach, you may not see that, so it's a bit more tricky. So the patient's got a nice healthy ear canal. I just wanted to mop up some of this dead skin because it was quite lateral. Again, I was just telling the patient just to remain as still as possible. And so there's a bit of dead skin a bit further in here. I'm just trying to hover over that, and I wasn't going to go for any more in terms of that more deeper layer of skin. So there's some dead skin a bit more laterals near the entrance. And again, I was using a fine end gauge here, so it's less noisy for the patient. So for any earwax removal specialists watching the videos, you probably have seen a trend in my procedures that I always target this weak spot, which is at the rear of the entrance of the ear canals. There's a little blind spot, should I say, if I can get my words out. So again here, so this is the patient's left ear, so we're on the posterior, so the back part of the ear canal, on the lateral canal wall. If you can lift the plug of wax off this canal wall, it really does help with the rest of the procedure. And this wax was a bit more firmer, a bit crustier in consistency. And again, I'm just trying to lift it off the canal wall. Similarly to the patient's right ear, I was just talking to the patient, just reassuring them, just so they remain still. Because I know I've got a steady hand, so I'm not going to be causing any trauma to the patient. It's just when the patients move themselves, that's when you're going to have possible injury. Because as I said, the ear canal is so narrow, it's not a large orifice, and so as long as the patient themselves can keep their head still, we'll be fine. So I've just used the ear hook again. Now sometimes an ear hook, you don't always try to remove the wax with an ear hook. You're just trying to disrupt the plug of wax, break it up, almost like a hammer and chisel, break it up into little pieces, and then go back in with a suction probe. Now with a patient who's quite anxious, you wherever possible, you want to avoid using ear hooks and Jobson horns or forceps very deep in the ear, in the sensitive the sensitive inner 2/3 medial canal wall, which is the bony part, which is the sensitive part. You just want to avoid contact with the canal wall wherever possible. So again, I'm just using suction and I'm just wriggling this wax. Now this is a huge piece of wax that was stuck in the patient's ear, and when I pulled this plug out, it separated into two. you'll see once I got this out, I was hoping it all comes out in one piece, but it didn't. You can see there's another plug there, which is past the second bend. It's quite deep, and again, the patient's very anxious. Just talking to patient through, just advising them that although the wax is deep, there's a bit at the entrance that I can suction onto to pull it out. It does actually help when the wax is a bit firmer like this, when you've got an anxious patient, because if it was all wet and gooey and slushy and mushy in consistency, it's a lot harder to remove, and you'd rather it come out in big plugs. Here we are. You see it's separated again. So I've just advised the patient to attend more regularly. It's been 2.5 years since the last attended. You can see the patient's got a very bendy narrow ear canal. There's the patient's eardrum.